Martin, do you think the data that we collect and use in the NHS reflects the things that are important to clinicians and, importantly, to patients?
Yes and no, of course, is the answer to that. There are some specialties where extensive, detailed information about quality and safety and outcome do exist and are available for both clinicians and patients and their families to see. And there are others where it's a complete desert, where there's just no information, or finding it becomes a complete lottery. So the lack of consistency and the lack of uniform availability of information and variable quality, and I would add variable presentational quality, is also relevant.
What changes would you like to see in a nutshell?
Well, in a nutshell, I would like to see all specialties being committed to collecting information and making it public. Now, how you define the information is going to vary, and it's not going to be an overnight phenomenon. It's going to be a journey to make your outcomes as a service available to the public. So if I do a particular procedure on a child, which is what I do, then I think it's right that the results of that should be available for other parents with similar problems to be able to look up and compare across the country. So it's easy in surgery, much more difficult in gastroenterology or dermatology. So you have to start with the easy hits, get those standardized and done, spread out across the NHS, and then move into those more difficult specialties as time goes by. And think about the way in which people search for the information too. It's no good just sticking it up on a website that's not easy to find. It's got to be Googleable or some other search engineable to be found.
Yes, that brings me on to another question. You've talked about the way that your patients use information and comfortable with using Google and social networking sites, etc. Do you think the NHS needs to change the way it collects and shares information to keep up with social trends?
Well, it must. And it must put effort into understanding the relationship between confidentiality and communication. We all understand the reasons and the need for patient confidentiality, but working in a clinic with young people, as I'm privileged to do all the time, they all want me to talk to them by email.
Yes.
And, obviously, it's not quite fair to say all, because some people still don't have access. But the vast majority of young people have a cell phone or a smartphone and access to the internet, either at home or at school. They just know how it works, much better than I do at my advanced age. And they expect me to be able to communicate that way. Children under the age of 20 largely don't use email. They'll communicate by Facebook.
Yes.
So we have to think of what that means if we're trying to communicate outcomes, quality, safety information. If we want them to talk to us and tell us how they are, which is what's important, and what matters to them so that we can test ourselves against their expectations, then doing it in a closed environment is like selling using an 1899 copy of the Times with all the classified advertisements on the front, when actually everyone's reading a tabloid. And beyond that, they're onto an iPad. So wake up, everyone. We've got to find a way of allowing the NHS to move forward in the way the customers want to use it.
Absolutely.
And more market research to know that.
What do you think that trusts need to do to promote a culture in which data is collected, recorded accurately, shared, and then used to drive quality and safety improvements?
Well, key to this is the board. Without leadership at, first of all, board level, CEO and non-executive directors, chairman of the board, they have to be convinced that that's important. If they're not convinced, if they think the money's more important than the patient, you're stuffed. So the first leadership has to be right. That can then trickle down through the organisation to be a way in which every area has leadership which delivers those things as being important. I think once you've reached that stage of institutional commitment, the next stage is then the detail of how it's done. That's got to be learning good practice from others, looking for the cheapest and most effective way to do it, finding out what's worked and what doesn't work, and some sort of library of best practice within a massive organisation like the NHS, which is easy to access, would be of great value.
You talked about your ambitions in Great Ormond Street to share your outcome data publicly. Does that, do you think, create an added incentive for clinicians to improve performance?
Yes, publicly is a word that can be phased in as well. So you can start off as, I use a surgeon as an example, start off privately as a surgeon, I'm a bit worried about my results, but I'd do a few more and just check it's all right, versus I'm showing my results to my department all the time, to my department discusses its results publicly in front of all the staff, to publicly in front of the hospital. It's then no leap to go publicly to the profession or publicly to the public. It's that initial move from secrecy to honesty. As I said in my paper, we're servants of the people, not guardians of some sort of secret. Our job is to deliver, ultimately, the honesty about the way we work and what we believe in. And you can't do that by lying to people. They spot it instantly.
Yes.
So you've got to tell the truth.
Yes. But it takes time to do that, to help clinicians to feel comfortable.
Yes, and we still live in a punitive environment. It's still litigious. It's still suspend rather than improve. And that has to change.
Martin, you talked about benchmarking Great Ormond Street with international best practice with Cincinnati Children's Hospital. Is that something that only applies to teaching hospitals, or is it something that local hospitals like Mid-Staff should also be expected to do?
Well, we talked about it a bit earlier as what the board thinks. So if the board wants to know if it's any good as an institution, the first question is, who am I going to compare myself with? So yes, of course, it doesn't matter whether you're the worst hospital in the country or the best, because you're trying to get better all the time. Being the same isn't good enough. So even the best hospital may be worse than all the others in the world. You just have to find the benchmark that's above you, look for the best in class and aim, and that's the performance gap you've got to fill. So I really passionately believe that Staffordshire Hospital, any Stafford Hospital or Mid-Staffordshire Inquiry, wherever you base your baseline, that is where you start, and next year you have to be better. So you do need to know how you stand in relation to the rest of the people.
Martin, thank you. The treatment of children in hospital is obviously different to that for adults, but I think there's many, many applicable lessons that you shared with us today, so thank you.